So from a provider standpoint, though, again, what I like about evidence blocks is that they're that great, just visual. But
Right.
Whether it's Drug Abacus or ASCO's value framework,
Right.
it's hard to see a lot of differentiation. When you look at some of these diseases and the drugs that are available. If there was such a situation where one company decided to really make a move and discount dramatically, would that impact the provider? Or if that discount isn't shared by the patient and the provider, it's only absorbed by the specialty pharmacy and payer, is that going to be something which is going to influence your behavior?
Well, first of all, it's going to be hard for us to know how those monies are shared unless it's from the patient perspective. But again, I would say, if all things being equivalent in terms of efficacy and side effects that would be manageable in that particular patient, then I think costs would become a bigger factor.
I see a lot of challenges, though, today in version 1.0 of the ASCO value framework or the NCCN evidence blocks. If you look at the NCCN evidence blocks for relapsed multiple myeloma, they give the same number of blocks and the same configuration for bortezomib, dexamethasone, phthalimid, dexamethasone, and carfilzomib, dexamethasone. They get 4 blocks across efficacy, safety, consistency, and quality of data, and then they vary on the cost.
By one block.
Yeah, and so if you were to look at that, you'd say in relapsed multiple myeloma, everything else being equal except the cost, we'd use phthalimid and dexamethasone, but I don't think that's the standard of care. So I think there are some things that have to be worked out there too. And likewise, daratumumab, Darzalex, that was just approved based on a single-arm phase 2 trial. They give it 4 blocks across for quality, safety, consistency, efficacy, based on one single-arm study. So the point is, I don't think we're ready to use any of these tools quite yet in making decisions on what's preferred or not on our formularies, and I'm not sure how physicians are looking at those tools.
Yeah, I would say most of them probably aren't looking at them. I mean, the value-based framework from ASCO, I'm not seeing an update from their initial presentation. I did see the NCCN blocks, and I think the only good thing about these 2 programs is it does at least increase the physician's awareness of the toxicities and costs, and gets them thinking more about costs and maybe what they would have done in the past. But I think the information is too vague to really make a huge impact. Yeah. We need I think more specific numbers, and I think that would tell a different story.
So there's a question. If many of these agents are never going to be tested head-to-head,
Right.
It's not in the manufacturer's interest to do so.
Right.
And so there seems to be a great call for real-world evidence. And as the statistical validity of such research is becoming more and more proven, do you think providers will be comfortable in real-world evidence-based analyses to try to answer some of these questions?
Well, I mean, obviously that's the idea behind ASCO's CancerLink or Flatiron's program, is to kind of get the collective experience of doctors from around the country and be able to make some inferences in terms of what therapies are better, which are less toxic, and then of course we'd have the cost data to those programs. And obviously that looks like a very good strategy. That sounds good on paper, but really trying to get that information and make those analyses is much more complicated than anybody can imagine.
We need a sentinel example of how real-world evidence could influence outcomes, and then I think everyone would get on board and support that. The question is, who's going to pay for the collection of that data right now? But Bruce, I would agree with you that we would like some real-world evidence in the absence of head-to-head trials to show what the relative benefits of these different strategies are.
The tough and the continued conflict between population health and when you hear about the impact, and direct patient care, which you live in every day. And I don't know how, as a nation society, we come to terms with that. But we're going to have to, right? I mean, it's inescapable.